Health and Wellbeing, who's going to open our premiere. So I'll hand over to you, Deputy Minister. Thank you.
Thank you very much, Michaela, and good morning, everyone. It's lovely to see so many people joining us for this really special event, and I'm really grateful to have had the invitation to come and speak at it. Health and social care, as we know, have faced extreme pressures and challenges over the last couple of years. And the response to the COVID-19 pandemic has really highlighted the value of working together through difficult times. The dedication shown by health and social care, the third sector, and carers and families in supporting and helping vulnerable people has been a genuine inspiration. The work on the Charter is an example of this dedication and commitment. Practitioners throughout Wales have remained committed and worked together in these really difficult times to understand the needs and to work to improve the hospital experience for people living with dementia and their carers. The Charter premiered today has been a long time in the making, with Improvement Cymru, Alzheimer's Cymru, Dementia Action Alliance and other key partners working together before the pandemic to scope and co-produce a charter that connects to our vision in Wales. The pandemic, as we all know, has delayed the full launch of the Charter, but as we heard at the promotional event last year, the practitioners, agencies and those with lived experience of dementia have worked really hard to maintain momentum. As we've emerged from the pandemic, I've heard so many people and services say that we need to build back better, and I think the Charter really helps us to do this. There are many reasons we need better dementia care in hospitals. At any given time, around a quarter of hospital beds are occupied by people living with dementia who are over 65. 42% of unplanned admissions to an acute hospital of people over 70 are people with dementia, and the readmission rate for people living with dementia is far higher than for people without. The Charter asks that each health board, each hospital and each ward and department has a clear vision for dementia care. It also highlights the principles to help achieve that vision. I'm really pleased to see that each of the health board regions in Wales has a dementia board that is working in an integrated multi-agency way using the Dementia Action Plan and Dementia Pathway Standards at its core. In practice, this Charter should make a huge difference to those living with dementia. We know that amongst the challenges they face, going into hospital can be really difficult for those living with dementia and their families. And I know from my own family experience just how important it is to have the right support when someone you love is in hospital with dementia. On top of the worries faced by anyone going into hospital, people living with dementia are faced with additional communication challenges. This is why our workforce needs enhanced learning and development opportunities to support caring for those with dementia and their families. The Charter will be vital in supporting people when they need care within a hospital. How people are engaged, empowered, enabled and cared for is crucial in providing a positive hospital experience, and properly preparing our workforce to deliver this is vital. It has been wonderful that practitioners, people living with dementia and carers have been connected by engaging in all the Charter virtual focus groups, joining the Inpatient Practitioners Network and providing feedback and suggestions for change. This is engagement and co-production at its best, and we now have a Charter to be proud of. We know there's a long way to go in changing for the better the experiences of those living with dementia when they're cared for in our hospitals, and this Charter is one step in meeting the ongoing challenge we are facing. I'm hugely grateful for the positive, co-productive and inclusive approach which is taken to rising to that challenge. I would like to end by giving a huge thank you to all those involved in this work, which I really believe will improve dementia care within our hospitals. Diolch yn fawr.
Yeah, thank you so much, Deputy Minister. It's wonderful to have you here today, and I just want to say thank you, because your commitment to the dementia care agenda in Wales knows no bounds. So thank you very much. And thank you for joining us and taking your time to join us. So we'll move now further into picking up the programme. We've got quite a challenging programme. We're going to be sweeping you off into breakout rooms, but we're also going to attempt a couple of panel sessions that are going to be, I think, quite interesting for you to hear. So if we go and move into our first presentation, I think Sean is going to load the presentation for us. And so this is from us in Improvement Cymru. The team and the core team we've been working with are going to be taking you through a presentation. So I'd just like to introduce the core team that have worked together on developing the Charter with our many partners, so many to name. We'll try later on. But our team in Improvement Cymru and Sean and Nigel. So we have the fabulous team of Rebecca and Ian from Improvement Cymru and Sean from the Alzheimer's Society Cymru and Nigel from Lifestyle Dementia, with a little input as well from Kerry Higgins. But you've all been fabulous, all wonderful, working on this presentation. So we're going to set the scene a little bit and give you some context on the Charter. So the Charter represents many things and speaks to and for many people. The journey started back in 2019, and we have managed to stay connected with all the people involved during a very difficult time. The Charter has a vision statement and principles that have powerful messages for the staff that provide the care across the hospitals, for the organisations and for the Welsh regions. Please use the Charter to support improvement. Don't let it sit on a shelf. The Charter speaks to people living with dementia, their carers, family and friends, and it tells them this is what you should and can expect. This is how we will work with you, we'll support you, care and enable you. The Charter tells us that staff learning and development is fundamental. So improvement is at the whole core of the Charter, and the team will now tell you a little bit more, take you into a little bit more detail. So over to you, Rebecca.
Deall, Michaela. As many of you will know on this call, the Always Pathway of Standards was launched in March 2021, and that Standard 11 is for Wales to adopt the dementia-friendly hospital charter with a regular review of implementation and outcomes. So the purpose of the dementia-friendly hospital charter for Wales is outlined in the document itself. And at the heart of the Charter lies the aim to enable hospitals to create a dementia-friendly culture, experience and the right environment for people with dementia, their families and their carers across Wales. So the Charter provides a focus for people living with dementia and their carers whilst they are in hospital, and outlines the care, the treatment and the understanding and the expected to achieve the vision of the Dementia Action Plan. The implementation of the Charter is something which is also one of the solutions mentioned in the Alzheimer's Society cross-party group on dementia report on the hospital care in Wales. So we'll be hearing a bit more about this from Sue Phelps, Country Director of the Alzheimer's Society, later on. Next slide, please. So in Wales, the Charter will focus on the following areas, and what we'd like you to see is support once the Charter is implemented. It aims to offer a short, accessible and visible statement of the principles that contribute to dementia-friendly hospitals. Enable hospitals to create a dementia-friendly culture, experience and the right environment for people with their families and carers. It will focus on improvement. Build on the needs of people with dementia and their families and their carers and what they can rely on when they access a dementia-friendly hospital. And build on the foundations offered by the Royal College of Nursing, staff, partnerships, assessment, care and environment, space principles. and offer an implementation framework to assist hospitals in their self-assessment against the dementia-friendly principles. Over to you, Sean.
Deall, Rebecca, thank you. As mentioned in the previous slide, the Dementia Friendly Hospital Charter for Wales builds on the foundation offered by the Royal College of Nursing Staff, Partnership, Assessment, Care and Environment SPACE principles. SPACE is a set of 5 principles that form a shared commitment to improving care for people with dementia and their families. Based on evidence gathered from people living with dementia, carers and practitioners, each principle is considered essential to ensure the appropriate delivery of care. Developed by the Royal College of Nursing and updated in 2019, the principles are designed for use in a wide range of health and social care settings and are used to inform the Charter. During the Charter consultation, stakeholders felt that 2 extra principles were required. Therefore, volunteering and governance are included. These are the 2 extra principles which you'll see at the bottom of this slide. And over to you, Ian.
Thank you, Sean. In order to assist health boards in thinking about the SPACE VG principles, Improvement Cymru have been working with the University of Worcester, who have developed a Care Fit for VIPs online toolkit, alongside a web company called Crystal. This online toolkit will help to incorporate elements of the Charter principles, self-assessment questions, and the ability to plan and record improvement projects related to dementia care. Crystal, who are the creative digital agency, have come up with the branding and layout of the platform. Above is an example of what you could expect to see on the page. And we're very pleased to say that the Care Fit for VIPs Welsh version is ready to go into the pilot phase. And we're working with wards across 3 health boards to get the initial impressions and feedback on the platform. Next slide, please. This year has been entitled the Readiness Year, but also offers the opportunity to get start addressing principles of the Charter. On the left-hand side of this slide, you will see a picture which represents the journey that wards may need to take. We start, as always, with thinking how things are at the moment. The current ward structures and routines are likely the same as they have been for a long time now, with an emphasis on completing tasks rather than focusing on offering individualised, person-centred care. We need to think about identifying and developing a culture that is wanting to improve and focus on the experience of the patients. And starting there is always a good place. No one person can do this alone, and nor should they. This will definitely be a team effort. When thinking who is on that team, always include people with lived experience and their families and carers. This will enable you to get a true sense of what being on your ward will be like. Work with your team to develop plans for improvement, decide your measures and do your PDSA cycles, and then decide, has this made a difference? Has this change made things better? Then keep hold and embed the changes that work and leave the ones that don't behind. Unfortunately, this is not a quick process, and it may be starting with very small goals at the beginning just to get the ball rolling, and that this is a long-term plan. On the right-hand side of this slide are 3 cues from the strategic view to implement over the next 12 months. From a strategic point, the first is get ready. So set up the work streams and get those key people involved. Get a plan of action in place. Do your baselines, collate your evidence, decide your approach and what you're going to measure. Once you've done that, it's really about getting going. Start implementing your plan and start thinking about a phased approach across your health board. Things like the Care Fit for VIPs online toolkit will help you do this and help you self-assess and understand maybe some small change ideas that you might wish to start with. And then it's about evaluating, going on to review those plans. What was the impact of the changes that we made? Did this do what we needed it to do? Or what else might we need to do to bring this plan to fruition. I'm now going to pass you on to Nigel, who is going to talk to you more about co-production.
Thank you, Ian. Good morning, everybody. The hospital charter from the very start followed an emphasis of co-production. Cleside Dementia as an independent voice were involved from the very beginning, providing strong voices through the charter development with an emphasis on safe care, which is person-centred and underpinned by kindness and dignity, which are considered within the principles throughout the charter. But co-production is more than two words, or hyphenated words. Co-production is a relationship where professionals and citizens can share power to plan and deliver support together, recognising that both have a vital contributions to make in order to improve the quality of life for people and their communities. And then to achieve this by the three most important skills at our disposal, which are communication, relationship building, and critical evaluation. Co-production is a word often used to describe the creation of a dialogical space, where service users, family members, carers, and service providers enter a collaborative partnership to improve their own care and service provision. Co-production should now be the cornerstone in the delivery of dementia-oriented services for people in Wales, in the spirit of the practical delivery of the Social Care and Wellbeing Act and the Good Work Framework. When this is implemented correctly, the idea of co-production should have the power to achieve positive change, including making services a lot more responsive to the needs of those affected by dementia, their loved ones, and carers. This negotiated shift of power should be welcomed as a way of ensuring that such relationships are based on care that is both practical and therapeutic, and ultimately can flourish. By talking to people and understanding and being sympathetic to what they really need and doing something about it is a certain route to providing meaningful change. Thank you. And now I'm back to Michaela.
Thank you, Nigel. Very, very powerful message there, because I don't believe you can go on a journey of improvement without true engagement and co-production at your core and at the start. So thank you very much, Nigel. Nigel, we're just going to go into a little segment which where I'm going to ask you a couple of questions. Is that okay?
Yes, fine.
So first question, why did you want to come on this journey with us for developing a hospital charter?
Well, first off, I've got dementia and it's very important to me. But secondly, hospital admissions can trigger confusion, distress, and sometimes delirium. For someone for dementia, it can be a very, very frightening experience for both the person with the diagnosis and their carers. The purpose and outcomes of the hospital charter is to make a space for an improvement in the experiences of people affected by dementia in hospital care settings. You know, an experience that recognises their personal diversity and preferences and is shaped by recognising the importance of dignity, respect and kindness. Be kind, be brave, know what good is and know what bad is. And see us not just through the prism of dementia, but as people.
Oh, thank you, Nigel. I have another question now for you. What do you want to happen next then? You know, what do you want people to do with the charter?
Use it as a framework. Look at its principles and see how much they apply to you as professionals, and use it as a framework. Right now, hospital care, for its very reasons, has a culture of task-orientated delivery, when it should be person-centred. Each person is individual. I know it's the hard road to travel, and I know the pressures that people are under, but with slight little tweaks, you can make the stay more comfortable by looking at by looking at people as people and using at your disposal all the skills that you've learned as caring professionals. And probably developing a new way of delivering care, because if you get it right for people with dementia, you'll get it right for everybody.
So true, 100% true. That's quite powerful. And my last question to you, Nigel, it's the $60 million question, this one. Can we change the world in which people living with dementia live?
Sure you can. You can't cure it. Right now, wherever I go, I take my dementia with me. At this very moment, you're all affected by my dementia. So it's everybody's business. I wish I could leave it at the doorstep. You can't. But by tweaking it, you can make the world in which I live a lot better. And it should be, rather than treating my dementia, you should treat my environment. Rather than looking at the reasons why you improve my dementia, you should also improve my environment. Tiny little low-cost tweaks. Take an extra minute to think about what you're doing and be reflective in the practice.
Oh, that's it's back to you, Nigel. That's wonderful. Really powerful messages, and I think there are take-homes there for everybody to be able to sort of think about and reflect on. So I thank you, Nigel, for that. We're now going to listen to an excerpt of a carer's diary. So this has been recorded to help us understand the many stories that people have shared with us along the way about their experiences of care within a hospital setting. So we'd like you to listen now to these diary excerpts. Thank you.
Diary, 2nd of January 2017 AM. Dad admitted to hospital today onto a ward following a lengthy wait in the corridor of A&E on a trolley. This is me profile was handed to staff and explained in person about his likes, dislikes and what frightens him. Again, family member refused permission to accompany him. 2nd of January 2017 PM. Moved to another ward, we eventually located him. The staff share about an incident of agitation and being pushy with them. My dad was very frightened. The bed was next to the double doors that banged and the TV above his head. My conversation and the This Is Me shared that as a veteran, loud bangs and noises would frighten him. Had obviously not been listened to. Mum was really upset, as Dad wouldn't hurt a fly. Mum apologised to the staff. I said the staff should apologise to Dad. 3rd of July 2018. Nasty fall today. Paramedics advised conveying to A&E. Remained in the corridor for a long period. Staff advise us to sit in the main waiting room on the other side of the department. I insisted, as his main carer, he needed to be supported by someone who knows how to communicate with him, as he does not have capacity. I should be an equal partner in his care. 4th of July 2019. Visit to A&E with my mum. Neighbour sitting with my dad at home. Hospital sign above the door says if you are a carer, to make them aware. I explain that my mum, due to impairments and cognitive issues, may need support. Explained I am an unpaid carer and I need to return to my dad with advanced dementia. The reply: You won't get seen any quicker because you're an unpaid carer, I can tell you that. So disappointing that my mum's needs as a disabled person were being ignored. 10th of March 2020. On ward with COVID. No access to visit. Understandable, but hard. No option available to talk over phone or FaceTime. The ward calls. How do we get him to eat? He won't take his tablets. I shouldn't have to keep reminding them he's on a softened diet and needs thickener again.
That's quite powerful, isn't it? Very powerful to hear that. So thank you to those people that shared their stories to create that diary entry. So I think along with Nigel's session and the diary session, we've got some powerful, emotive feelings here about dementia care and getting it right and what we need to be doing. It is very, very, very powerful. And we're hoping that today in the Charter, we can't ignore the reality of what is happening, but we hope today and going forward will be about how we change for the better. So I'd just like to, on this last slide, say a huge thank you to the people that have been involved in developing the Charter. We've had all kinds of people, hospital staff, all grades, all disciplines, right across the settings. We've had third sector agencies, and we've had people living with dementia and carers providing us with real insight and challenge on being able to get this right. So I thank you all. We have a special thanks to Lifestyle Dementia, Nigel, Kerry, Francis, Andy, Chris and Jane, and many others. And also Sarah Tilzed, who started the journey with us way back in 2019 with the Dementia Action Alliance. Sean Jones from the Alzheimer's Society Gymru, and the team at University of Worcester with Professor Dawn Brooker, Jennifer Bray, and the rest of the team. And also to Ian Bennett and the Crystal team that have worked with us really, really hard on being able to develop the online self-assessment tool, Care Fit for VIPs, that Wales will be using going forward. And a huge thanks to Frances Isaac for her wonderful paintings. This background and the Charter has Frances's paintings all the way through it. So thank you, Frances. So also we've got a great team, I think, here, and I would like to thank everybody in that team, Improvement Gymru team. Behind the scenes, it's a frantic, mad rush, but everybody steps up to the challenge and they're absolutely amazing. So we also have a Padlet that's being created. All the presentations, the slides and everything from today will be available on that Padlet tomorrow. And most importantly, that's where you will access the Charter document. So it will all be in one place for you to be able to use. So everybody on the call will receive that in a Padlet. You just open it up and you'll find everything you need to in there. So to everybody involved, thank you, Deall yn fawr iawn. And we'll move on to the next session now. So I would like to welcome the next panel. Well, it's our first panel, actually. The first panel here, where we're going to be hearing some conversations with a few ward managers. So without further ado, I'd like to hand you over to Andy, who's going to lead the panel and help us listen to some of the experiences of those ward managers in being involved of the trial of the Care Fit VIP self-assessment tool. So thank you, Andy, and thank you everyone involved.
Good morning, everyone.
Good morning, Andy.
Morning.
Have we got your two ladies here?
Yeah, just for clarification, I'm living with dementia, so I couldn't concur more with some of the comments that we've heard earlier. Extremely powerful and very important to people like myself and my carers, especially as Kerry mentions the unpaid carers. We've got a couple of questions that I think we need to pose, really, and they're important ones related to the launch of this charter. None of them trick questions. I think all extremely relevant. The first one is, what are the challenges to providing dementia care in your area, and how have you tried to overcome these? Would anyone like to chip in there and perhaps give a view on that particular question?
So any thoughts, Donna?
Yeah, I'm happy to answer that one if you want me to go ahead. So I'm the ward manager of Oak Ward at County Hospital, and some of the challenges that we found within our area, I'd split it into two sections. The first thing that we identified was isolation for our patients and lack of stimulation within the hospital environment. And we found that led to poor outcomes for our patients. So some of the things that we've done to try and overcome that is we've introduced an intergenerational project with one of our local primary schools, by which our patients and our children communicate with each other through COVID. We've had to do it via Teams, but we hope to develop that in the future. But we do something called a Smile in the Bag project, where the children will send things into the patients, and then we'll do activities with our patients and send them back to the children within the school. And we find that really helpful. And we've also introduced a PCA role within our environment. So it's a patient care coordinator, and they come in outside of the healthcare support role, worker role, and provide activities for our patients throughout the week. So it can be something like a big activity, or it can be something smaller where they'll spend time one-to-one with the patient doing hair, nails, maybe helping them to have a bath or a shower, or something that's meaningful for that patient. So that's something we've done to try and tackle that. And in relation to the other point that we found was a challenge was education for our staff. So last year during Dementia Action Week, we provided a whole week of activities and education, and every day we did something different. We signed up 100 dementia funds within that week, and we've also recently managed to get 80% of our staff trained on the dementia training programme provided by the Health Board, and that's something that we've done to try and overcome our barriers, really.
Thank you, Donna. Training is just really important, I think. It's something that I personally get involved in because it's something I'm passionate about. I really do think it's important that anyone involved in care, regardless of which medical discipline it is, needs specific training. Any further comments on that question are very welcome. Donna, you certainly came. Oh, okay. Sorry.
Yeah, I don't. I think Donna put her hand up before myself, I believe, or was that just me? I'm not very good with technology. On a good day, you have to excuse me.
No, you go ahead, Diana.
Okay, so I'm sort of representing from a different sector. So I obviously work for a private healthcare service rather than an NHS. And what we found, what we struggled with in relation to is staffing. Now, I know, especially during the COVID situation, it's been quite a chronic issue with us. So what we did, because we find that familiarity and being able to recognise who's who and having a face that you know and recognise is very, very important. So we worked with the agency staff and what we did was a block booking programme for nurses and support alike, where that they would basically become, even though they were agency, a regular member of the team and provide them with the same uniform as us. So then they are able to get to know the people who have this illness as well, and are able to understand their individual needs and support them just as employed staff by the company. So we found that really beneficial as well, and due to us being a complex care situation, we noticed that helped in the reduction of numbers of incidents and things that we had as well, which benefited the client group that we're looking after. And something we struggled in throughout COVID, because we were very dependent on other members of the MGT in relation to supporting with activities, again, as already highlighted, dementia care currently and has been for some time, unfortunately, task orientated practice. We're very healthcare is very in the medical model rather than the individual and psychological model. So what COVID taught us is for each ward to become self-sufficient and for us to think outside the box. What can we do when such services are not available? How can we provide what's being provided to a degree without that extra support there? And we've been able to sort of develop ward run activities, so shadowing, where we've trialed things, some have worked, some haven't, and we've sort of kept the things that have and binned the things that haven't. So that continues to be an ongoing process as well. So each ward becomes more self-sufficient in meeting the needs of people.
Thank you, Diana, for that contribution. I think in the interest of time, we've got 4 questions to cover. Let's move on to question 2, if that's okay with you guys. I wonder if you'd be able to tell us, obviously, as a result of the new hospital charter, what you understand about the Care Fit for VIPs online toolkit. Any comments on that particular issue?
I don't know if somebody else wants to add, because I've already said something.
Yeah, I think some of these questions do overlap, so they're similar things, but I don't know if there's anything specific you'd like to add in that particular area.
I'm happy to speak if nobody else is going. I understand.
That'd be lovely, Donna.
Yeah, I'm happy to. I understand that the toolkit is a guide to help us make our wards dementia friendly. It can guide us and give us a focus on what's important for our specific areas, but it's also a self-assessment. So it helps us identify our positive areas and our areas for improvement. Is what I see it as.
Hi, can anybody hear me? I'm not sure.
Yes.
Oh, hi. I wasn't sure if my mic is working. I don't have a video that's working. I'm Ellie. I'm a ward clerk on B4 in the Grange, the stroke ward, and I'm a dementia champion and very, very passionate about it. And I just wanted to say that we're using the dementia daisies. We're on top of that if someone is identified as having dementia, or they may not come in as being identified as having it, and we may just spot it on the ward, the nurses and the care and the healthcare support workers. So yeah, we use the dementia daisies. And then we also use those, we've had the baskets, which we only just recently delivered to the ward, and we plan on using the meaningful and engaging dementia baskets, and they look great. So just wanted to say that, we are mindful of it and doing our bit. And I can't speak for the ward manager because I don't think she's on this launch at the moment, unfortunately. But I know that she was proactive in trying to release the staff to do the training, because as you said, a person previously said it's very important for staff to do training. But that was just that's just what I wanted to say. Thank you.
Yeah, no, thank you for that contribution. Yeah, the Dementia Daisies are great, obviously in and out of the hospital environment. I wear the lanyard and the little pin myself, and that helps. I know earlier hospitals have used other indicators. There's an up and a downside really to that, which is obviously the Dementia Daisy is important because it gives you the sign, isn't it, that the person has dementia, but it's still important to look at the person as well as the dementia. But definitely the daisies do help. I think one of the key things for me was that came out of this presentation were the strap lines really be kind and brave, and provide safe care. That was those were the things that that stuck in my mind, if you like, out of the things that came through, and just seemed really important to me about understanding the care fit for VIPs. Let's move on to question 3. The dementia-friendly hospital charter for Wells has been developed to support improving dementia care. How do you see the care fit for VIPs online toolkit helping you with this?
I'm happy to speak if it's Diana it is, if nobody else
Yeah.
wishes to. I'll keep it brief. It supports us in breaking down the hospital charter into sort of bite-sized chunks, because if you go at the charter sort of bullhorns at the ready, it can be quite in-depth. You can get lost. You could end up covering areas that you don't actually need to focus on at the moment. So it enables us to break that down, give us key areas to focus, and ensure then that we're meeting those standards over a period of time as much as possible, and regulate for improvement.
I think Donna, I think you wanted to say something as well.
Yeah, I'm happy to. Some of the things that I've noted down that I think make it helpful for us is that it gives us a baseline to work from, and it prompts us to think wider, which we might not necessarily do if we didn't have the toolkit to refer to. It also helps us to involve others, the wider MDT team, partnership working, and it gives us a collaborative approach to providing dementia-friendly environments, with some of the things that I've taken from it.
Yeah, certainly the co-production issue in that diagram that we saw, I think explained how important it is to involve people living with dementia, early onset dementia like myself, and the carers in particular. As most of you know, I don't have to tell you guys, but dementia is something which affects the whole family, and it's important to talk to, in most cases, the unpaid carers who know perhaps a lot more, and have a good gist of information that is useful. So you know, it is important that when you're providing, you're looking to provide care fit for VIPs, then you know, you do engage in co-production. Does anyone want to add any more on that particular topic? It does demand, I think, a detailed knowledge of the toolkit, and I think it's something that we'll become more familiar with over time as we put together our plans. But I do think it's an important part of achieving the charter. better care for
I just
people with
wanted to
dementia.
add, Andy, if you didn't mind, that
No, please do.
I think one of the good things about the toolkit is that every department within every service at the moment is under significant pressure for one reason or the other, for another. And I think one of the important things about the toolkit is that we can still achieve even though we're under them pressures, because some of these things are just small changes, and by using the toolkit you're still achieving by just doing little bits of the toolkit. It doesn't have to be a huge project, but we can still use the toolkit to guide us to ensure that we're achieving dementia-friendly environments, even under the pressures that everybody's under at the moment.
I agree entirely with you, Donna. Thank you for that. You know, resources is the unmentionable word, but clearly everyone is struggling under enormous pressure, be it resources or the pandemic, and trying to catch up with various issues. So you're right, it is important. I think some of the things in the toolkit are quite simple steps to take too. So I think you know, it provides, if you like, a roadmap, doesn't it, to achieving these things. Before we move on to the final question, is there any other comments that anyone would like to make regarding this particular issue? I think I've covered the unmentionable. Oh, Francis.
Yes.
Yep.
Hi, Andy. Yes, I would. You know, I know people sort of worry about the finances on all this and the training and so on, and the resources that it will actually require. But these are really simple things. It's a simple thing of making sure that that person can reach the water that you put in front of them, can eat the food that you put in front of them. Little tiny things, asking them if they're actually, you know, needing anything, because it's very difficult for people with dementia to describe to you how they're actually feeling. I know from my own experience in hospital that you feel quite unable to actually flag up what it is that you really need, and it's very disorientating, but all it needs is just a little tiny moment of kindness.
Yeah.
And that costs nothing.
Thank you for that, Francis.
And
I think,
can I just sorry, a comment just to say to any final thoughts for the last 2 minutes, following on from the wonderful comments of Francis. Thank you.
Okay. Clearly strapped for time, but lots of input. The final question is: Care Fit for VIPs has a focus on improvement. Thinking of the indicators and statements, what are the areas that you want to focus on for your wards in the next 12 months? Perhaps you'd like to give a couple of examples. There are clearly values, the individual, partnership and social. Those are the 4 headings. Does anybody want to highlight a couple of important ones that come out of that list?
Yeah, so I think in relation for St. Peter's Hospital, I think individual is one that I think that we are looking to focus on, and ensuring that our care is provided on an individual basis. And again, training, I think that needs to be largely improved within our setting in relation to support we offer to people who have dementia.
Yeah, thank you for that, Diana. Yeah, I mean, as Francis has said, a lot of these are simple steps, and I think we need to look for those whilst resources are strapped. But clearly, we have to try and achieve all of them in order to give, you know, full value to the launch of this new charter. I think we've got a few seconds left. Does anybody want to add anything else at the end? Can I give a big thank you to the contributors? as you know, living with dementia, and I've really appreciated and felt invigorated by the comments that we've received from the people that have contributed to this little section of the day, for me in particular. So a really big thank you to you guys. And I think probably now, Kerry, we have to move on to the next section. Would I be correct?
Spot on, and I'm sure everybody would like to thank you, and I'm sure the team will thank you as soon as this session finishes. So thank you.
Yeah, lovely to meet everyone. This has been a pleasure. Thank you for having me.
And thank you also to Donna and Diana for the contributions for that. That was amazing. Really put on the spot there, and you've really raised to the challenge.
Yeah.
Absolutely amazing. It's something to really be excited about. People with passion and commitment that you've both shown. And I know all of the wards we've engaged with, all of the staff we've engaged with regarding the trial. So I think we can be heartened about what's coming in the next 12 months for our areas. Andy, I'd like to say lovely. A massive thank you.
Sorry to interrupt, but
can
I just make sure we don't forget the ward clerk who made a lovely contribution, and I've forgotten her name.
Helen.
And it was lovely that she was so passionate, because we forget our clerical people in hospitals and care home environments, and it's lovely that we had that passion from her.
Thank you.
Well, I thought that was really inspiring, and also always great contribution from Francis, who, like myself, is living with dementia.
Oh, I'd like to say a huge diolch yn fawr iawn to all of you all. Yes, and I think that statement will stay with me all day, and it will be our take-home statement. A little tiny moment of kindness is what Francis said, and I think if we can all keep that going in our hearts and our heads as well, that will stand us in good stead. So thank you, Andy. Thank you, Donna, Diana, and thank you, Helen and Francis, for your contributions. Take care. Right, we're going to go into the next session now. So I'd like to introduce Professor Dawn Brooker, MBE. Dawn can't be with us today in person. She's actually started her retirement from the University of Worcester and having a well-earned break before she returns later in the year. So that's a huge bonus for us, that she's actually not disappearing off into the ether. We're going to have her back, and she'll be able to still provide us with her expert knowledge. So Dawn has provided us with a video recording, and she's going to take us through person-centred care and caring for people who are in hospital with dementia. So we'll listen and watch the recording now from Professor Dawn Brooker. Thank you.
Okay. So, hello everybody. Really sorry I can't be with you here in person today. I've recorded a presentation around the VIP's framework and a few reflections on hospital care and people living with dementia, which I hope you'll find useful. So in this short lecture today, I want to start off by just expressing humility and thanks, really. For people living with dementia and their families, and for staff, hospitals are really difficult places to enact person-centred care. They're difficult to be in as a patient, they're difficult to visit, and if you are working with a number of patients living with dementia on a busy ward, they're also very difficult places from a staff point of view and a professional point of view. And I just want to thank each and every one of you for really, taking the time today and making the effort to try and make this right, because if we can get hospital care right for people living with dementia, that would be such a great benefit to all of us. I often use this illustration of poor old Sisyphus pushing a big boulder up a hill, and he's been damned by the gods that as soon as he pushes it up a few inches, the heavy weight of the boulder rolls down back on him. And often I think providing good hospital care for people living with dementia can feel like that. You know, we make a few breakthroughs, we get our systems up and running, we make our hospital more dementia friendly, and then we hit the next crisis and the boulder rolls back down on us again. And I think, you know, that this crisis that we've all been living through for the last few years of COVID has really taken so much strength and energy out of us all. And I think it's very opportune now to really start thinking again about helping people with dementia who are patients in hospitals and how to make it better for them. So this afternoon, or whenever this is being broadcast, I'm going to do my bit by putting my shoulder to the boulder and trying to articulate a bit about our evidence-based person-centred care and giving you an overview of the BIP's framework. Now, we actually have a very strong and enduring theory of person-centred dementia care here in the UK. The late Professor Tom Kitwood first started writing about the importance of person-centred approaches to dementia care way back in the last century, drawing on the work of Martin Buber and Carl Rogers, and really then recognising that people living with dementia were people first, you know, that dementia happened in the context of their lives. And a lot of what we have the opportunity to do in dementia care is to try and support the personhood of those living with dementia. And he developed some key enduring theoretical standpoints, like the enriched model of dementia. He talks about the importance of psychological needs in dementia, and this eradication of malignant social psychology and the promotion of positive person work. Now, these are heady theoretical things that Kitwood was writing about. And one of the joys that I had a couple of years ago was Kitwood's first book on dementia, on person-centred care, called Dementia Reconsidered. It was actually written in 1997, and it is such a well-thumbed textbook that any of you who have been students in dementia studies or who have ever delved into person-centred care would have come across. But it is an old book now, and essentially these are the 9 chapters that you'll see on the slide here that Kitwood wrote way back in 1997, drawing a lot on the work that he was doing in the late 1990s. And as the 20th anniversary of that publication came upon us, Open University Press asked me whether I would do an edited version of the book, whereby we took each of those 9 chapters and for each one had a contemporary expert in the field to write what had happened since 1997. And that became Dementia Reconsidered, Revisited, which there's a copy of on your screen. And essentially, virtually for chapter, what the contemporary experts were saying was that the theoretical models that Kitwood developed way back in the 1990s still stood today, but actually what we have now is a lot more evidence and know-how for how we enact these aspects of protecting personhood in practice. This doesn't mean they're easy to put into practice, but we do know already a lot of the things that really help people to live well with dementia or to have a good patient experience. What's really changed over that time period, though, is the numbers of people living with dementia and also the time that people are diagnosed with dementia. I've been working in the dementia care field for a long time, nearly 40 years now. And certainly when I first started working in the field, dementia was a relatively rare condition. You know, if we had somebody on an acute hospital ward with dementia, we'd immediately call a psychiatrist. If we had somebody in a care home with dementia, it was a big deal. Whereas now, because of our aging population and because we have so many more thousands of people living with dementia, particularly into old age, you know, so people in their 70s, 80s, 90s living with dementia, who, if you're in your 70s, 80s and 90s and you have a dementia, you know, the chances are you've got 4, 5, 6 other long-term health conditions going on as well. So of course you're going to end up in hospital. It's inevitable at some point. And also our care homes are now 70% of care home beds will be for people living with dementia. Now, those on an individual basis, for those people living with dementia, their lives are no less complicated than they were 30, 40 years ago. But now we are, as a health service and as a social care service, working with many more people. So now dementia is everybody's business. It's not specialist care. We still need our specialists to advise us, but by and large, all of us and all service settings need to be able to support those living with dementia. And the other thing that's changed is that we are diagnosing people at a much earlier stage. Again, you know, even I'd say 10 years ago, we were mainly diagnosing people at later stages when their capacity and insight to understand what was happening to them was becoming much more impaired. Now, with our memory assessment services, most people are driving themselves to their dementia assessment. You know, we are now have a whole cohort coming through, COVID permitting, who actually are being diagnosed with dementia at a time when they can talk about that dementia, understand what it means for them and their family. Nobody wants a diagnosis of dementia, but if you have one, at least that empowers you to take some control over your future. What's endured in that Kitwood work, though, I think, is that the recognition that people living with dementia, their psychological needs are paramount. And often, if they are in receipt of care in hospitals or in care homes, those needs can easily be overlooked unless we make a real effort for them not to be. And that's when the boulder starts rolling down on us, you know, when their people's needs get squashed and marginalised. So that is as true now as it was when Kitwood was writing it in the 1990s. And I'd share this quote here of, this was our experts, Keith Oliver and Reinhard Guss, who did the commentary on the Dementia Reconsidered Chapter 5, which was looking at the experience of dementia. Keith himself was diagnosed with dementia a number of years ago, and he wrote this about that Kitwood flower, about those psychological needs. And he said, an early collaborator and professional friend, Michael Miller, showed me the Kitwood flower and explained it in context, and then more importantly, consistently demonstrated through his actions and support what Kitwood would have wished all professionals working with people with dementia to demonstrate. And Keith said, I carry the Kitwood flower with me every day, glued into my diary. And if ever I had a tattoo, that's what I would go for. So those psychological needs, that need for attachment, inclusion, warmth, love, occupation, all of those things are important, whether you're a person early on in your diagnosis or whether you are later on in your diagnosis. And that's changed, that has endured. But what still challenges us is for that person living with dementia to experience care as though it's seamless. You know, people now live with dementia 10, 20 years. If you're thinking, you know, if we're diagnosing that early, people have got a long trajectory ahead. And still we treat care as episodes of care. We don't join that up around the person. And for each of these bits of this jigsaw puzzle, if we can't achieve that partnership working that is essential for the person living and dying with dementia, then at some point we are going to be failing people. So just moving on now to Care Fit for VIPs. We all need to know what good looks like. You know, what does good person-centered care feel like, sound like, look like? And who has to do what to make that happen in reality? And this leads me on to the Care Fit for VIPs definition. In trying to define the definition, I looked at lots of research from around the world. And it's a nuanced definition. I think there are 4 parts to it. It's more than just individualised care, person-centred care. If we're really going to be promoting the personhood of somebody living with dementia, our care has to value people regardless of their cognitive ability or age. We have to make an active effort to value people. Of course, it has to respond to people as individuals and recognise that everybody living with dementia has their own needs. It though also has to incorporate that ability to take the perspective of the person with dementia. So for us as professionals to be able to reflect on, what does this service, what does this intervention feel like for this person? And it has to provide that supportive social psychology. We have to have a social milieu that helps people to feel socially confident and included. So if we look at that from an individual perspective of being a person-centered practitioner, we have to be able to show that our actions respect, value and honour this person. We have to be able to reflect that, you know, on our actions, whether we are treating this person as a unique individual. We need to reflect, you know, am I making a serious attempt to see my actions from the perspective of the person that I'm trying to help, and how might my actions be interpreted by them? And do my actions help this person to feel socially confident and that they're not alone? And you can ask these 4 questions of yourself, you know, if you're giving an injection, if you're helping somebody to eat their meal, if you're helping them to, if you're doing a leg dressing, or if you're running an activity group. It's not that the action itself, or it's not the activity itself is about is person-centered or not. It's more about the way in which something, the way in which that intervention is done. So it's not what you do, but it's the way that you do it, I think would be what would get your results in terms of preserving personhood. And that definition got picked up in the NICE guidelines in 2006 and again in 2018. So at the beginning of the NICE guideline on dementia, it says that we should be acting in a person-centered way, and it defines person-centeredness in accordance with that VIP's definition. And NICE guidelines only have things in them that are evidence-based. And so I think if we unpick each of those, we have evidence to suggest that if you enact valuing, individualised perspective and social environment on a regular basis, then the outcomes of people living with dementia are so much better than if we don't attend to that. So I then took this work a bit further. So we had this 4-point definition, the V, the I, the P and the S. And so looking at care provider organisations, what does that mean in practice? And more importantly, who needs to do what to make it happen on an everyday basis. So you see, we've got these 6 indicators here for valuing. And now I would suggest, mainly within a hospital setting, those are going to be set by the senior leadership team within your hospital. The vision, human resource management, management ethos, training and staff development, service environments, quality assurance and governance. Those are the things that are set by people higher up in the organisation. Then if we're thinking about how we deliver individualised care pathways, care planning, regular reviews, personal possessions, individual preferences, life story work, activity and occupation. If you're going to get individualised care happening on a regular basis, those are the sorts of indicators that you'd expect to see being fulfilled within a hospital. And those are all things that need quite complicated processes building around them. So those tend to be enacted and led by your clinical leads, your senior nursing, medical, OT, physio, paramedic type people who are going to be putting those into place on a regular basis. Perspective, how do we ensure that the perspective of people with dementia is understood? And that will often come down to whoever's in charge of the ward on that day, your shift leader, you know, who will be role modelling and monitoring skill communication, doing that balance between empathy, risk and decision making, ensuring that the physical environment is managed to the comfort of patients, ensuring that physical health needs are picked up quickly and enacted upon, responding to those difficult distress type behaviours or behavioural and psychological symptoms of dementia, and advocating for people when their needs are at odds with others on the board. And then we have the social psychological milieu and environment. Are people included or talked over? Are they respected or disrespected? Are they met with warmth or coldness? Are their emotions and needs validated or sidelined? Are they enabled or done to? And are we making an effort to ensure that they're still part of their family and community? And that comes down to everybody can play a part in that. So on a holistic, we're looking across a whole hospital, we need all of these things to be working together to ensure that person-centred care becomes a reality on a sustained basis. And that's where we also developed the Care Fit for VIP's website that you will hear about today, and that Improvement Gymru have put more effort into updating this website that we've been using since 2012 to really help underpin the work within hospital care for those living with dementia. And as you go through that Care Fit for VIP's website, you'll be asked to reflect on, when we look down those 20 odd indicators, what are our strengths? What are we doing really well? What are our weak spots? And what's my sphere of influence? You know, I might not be able to make all the training happen across the whole hospital, but I might be able to do a project around life story work on my ward, you know. So it's also about thinking each of us play our part, regardless on the level that we're working at within the hospital. So in a bit more depth here, you know, these would be the 6 questions we'd ask about, does our hospital really value people living with dementia? And for each of those 6 indicators, we would reflect on, are we doing an excellent job here? Happens all the time. Are we doing pretty good? You know, happens some of the time, or we've made serious efforts in that area. Are we doing okay? Yeah, it's a bit hit and miss, but we've got some areas of good practice. Or does it need really serious work? This is something where we haven't got off the ground at all yet. I'm going to be sharing some photographs of people, some lovely group of people that I work with in Wolverhampton NHS Trust in the Midlands near my university at Worcester. And that's really your senior NHS Trust, you know, your chief executive, your director of nursing, your lead consultant, your medical director. Those will often be steering what happens at that high level of valuing patients with dementia in hospitals. And, you know, thinking about what happened in England, certainly with the national audits of dementia, because there was a very big push to audit at a quite a public level how well hospitals across England were doing on the different standards within the national audit. You know, that was something that trust boards took very seriously in England. And we saw some very big strides being made on defining the dementia care pathway. The percentage of hospitals that had a dementia care pathway was only 6% in 2011, and increased to 2016, had increased to 61%. Having a dementia lead went from 0 to 97%. At least somebody got the title that it was in their job, even if they weren't perhaps actively doing it. Dementia training and hospital board reporting. So at that high level, you know, the work you've got going on from Improvement Gymru will be really important in bringing this on the agenda of your higher level people working in your health boards. The next set of questions would be around supporting individuals living with dementia. Again, you've got these 6 indicators. Are we doing excellent, good, okay, needs more work? And on the website, you'll see each of these indicators unpacked, and it gives you the opportunity to really sort of make a good assessment of, well, how are we doing on these individual indicators? And as I said, these tend to be the senior clinical team. Again, we've got the modern matron, we've got the head OT, and we've got the lead consultant for care of the elderly. You know, that's the work that they often are involved in pushing forwards. And certainly, you know, this often starts with these sort of high impact, innovative pilot projects. So thinking about, okay, so what happens if we start using patient passports? What happens if we try really to reduce ward moves? What happens if we have a facilitated activity room within the ward for patients with dementia? So through these pilot projects, you can really start to move forwards on some of these more structural, individualised care indicators. And your next piece of the jigsaw puzzle is understanding the perspective of people living with dementia. Again, for these 6 indicators: excellent, good, okay, needs more work. And this is your ward team, you know, people leading the ward team at different levels and within different with different levels of responsibility. And certainly in this ward, which was a medical ward focusing on the needs of people living with dementia, they made a really serious effort to implement what they called a dementia care bundle, which meant that they knew key information about people within 24 hours through a This Is Me documentation. They did effective communication based on that This Is Me documentation. They really made sure that people were well fed and well hydrated, and they provided a safe and orientating environment. So applying that as a standard of care, that dementia care bundle, that meant they were putting in place things that would enable that person living with dementia to feel understood, to feel safe, and to feel included, was an important perspective type project. operating at ward level. And if you put that sort of behaviour change into operation, if you this is me as in completed on admission, it means you have good conversation topics, you know about signs of distress, you are recognising patients and families as partners in care, you improve your dignity and respect, you lower levels of distress. That will, of course, lead to improved outcomes, low levels of restraint, either physical or pharmacological, decreased untoward incidents and decreased complaints. Simple. And then finally, providing that ongoing social and psychological report, those things, you know, the inclusion, the warmth, the respect. How are we doing on that on an everyday basis? Excellent, good, okay, needs more work. And that's the responsibility of everybody. And forgive me, I don't know the name of this gentleman. This was a ward I was visiting, actually down on the south coast, and I became very, very taken because it was actually the ward that it was a ward that was named after me, and on that bucket it actually says Brooker. So I had my photo taken with the guy with the bucket. But if the guy with the bucket, who is part of that patient environment, if he's not showing inclusion, respect, warmth, validation and enabling and being welcoming to people's families, then the social psychological impact of that will be felt by the patient. So this has to go through all staff who have contact with people living with dementia. And things like John's campaign, you know, involving when somebody with dementia is hospitalised, the medical staff should do all within their power to make access easy for families and carers, and to utilise their expert knowledge and their love within that patient's stay. And to top it all, though, you know, is that sort of, we can get all that right in the hospital, but what happens when people are discharged from hospital, you know? Because if we don't discharge well, then either people will end up being readmitted to hospital quite quickly, or their health will deteriorate to such a level, you know, that and their quality of life could be very poor. And I just wanted to finish by sharing with you a set of photographs that are quite old now. But it was when I was working with a care provider called the Extra Care Charitable Trust. And they were doing a project on implementing person-centred care within their care home. And they were particularly interested in increasing their activities in the care home, and took a lot of photos over a period of a few months. And this was a picture, a photograph taken of Mrs. May Williams. And this was 6 days after she'd been admitted to this particular care home. And her care plan is in the yellow at the top of the page there. She'd been, she had dementia. She had been, had a hospital admission. She'd been quite unwell. She'd had a chest infection, had been in hospital, I think, for 7 or 8 weeks, and had become very poorly, but had survived. And she came to the care home with this care plan, which said all needs, no mobility, not eating. So in a sense, you know, she'd been, she was being discharged to essentially probably past and to end her days in an environment that was more conducive than an acute hospital ward. Now here she is 1 month later, and she's baking. She's making a bit of flapjack. She is she's been a homemaker all her life. She might not be able to make a complex Sunday dinner, but she certainly knows what to do with some sticky flapjack mixture. And here she is, obviously enjoying that. Good infection control, got her blue rubber gloves on, but obviously enjoying the moment of making and potentially eating those later. Here she is 6 weeks later. The home are doing an Italian night, and she's certainly looking a lot fuller in the face and looks like she might now be eating. Here we are, T and Teddy. Trying new things. She's having an Indian head massage here. I doubt whether May Williams had ever had an Indian head massage in her life before, but 2 months later was evidently enjoying that. Old skills returning. She, you know, again, might not be able to make a fair hour jumper, but she certainly knew what to do with wool and knitting. Silk scarves, activity. And 3 months later, here she is up dancing to music. And I think this was a Mexican celebration that they then had. And this is the same lady, you know, who was all needs, no mobility, not eating. And this, I think, illustrates for us, you know, what good person-centred care can do. The care home didn't think they were doing anything remarkable. They were amazed when they saw these photographs of May throughout that time period. You know, we could say there were lots of interventions that were going on there, that weren't particularly high level, but it was about that good quality, person-centred, everyday care. And the outcomes, obviously, I think for this lady, she probably wouldn't have been alive had she not gone to a care home in that took her personhood so seriously. So lots of people to acknowledge today, and particularly thanks to everybody at Improvement Gymru who's worked so hard on the launch today and getting this all sorted. And I just wish you all the luck in the world, and do keep in touch with us, and I hope to see some of you in the near future. Thank you so much for listening.
How wonderful was that? That was very, very powerful, very moving, and very, very thought-provoking, I feel. How wonderful we've got that video to actually, you can all take back with you and share as well when it comes out on the Padlet. I know a lot of people, we couldn't see all of the slides, but I think we got the messaging loud and clear. So the full video and the slides will obviously be on the Padlet for you, and I think this is an amazing learning tool. So yeah, thank you, Professor Dawn Brooker, for her time at such a busy countdown time that she was having. It was a great presentation. It can really help our learning and understanding. Yeah, and help us, I think, if we hold this dear. This message of it's everybody's business, I think, is something that we should take away and make a reality. It is everybody's business working with people with dementia. It isn't just the specialist services, it's everywhere. Every form of health, social care, including our partners. You know, we have partners across care homes. We have partners in local authority, third sector, in our community services. The hospital isn't just the hospital and that building. It encompasses so much more, doesn't it? And we need to really put that message forward as well, that people are coming in and out of hospital. They're coming from their homes. That could be their own home, in a street, in a town, in a village. It could be a care home in a street, in a town and village, but it's still their home. And they're coming into hospital. Those care partners we have in those care homes, cross community settings, are equally part of our whole approach to what we deliver within our hospital care. We must be inclusive. So I'd like to thank everybody who has taken us through this first morning session. We're now going to go into a break and come back and kick off with some more lovely presentations from people. So thank you, everybody, and we're going to have a short 10-minute break.
Great, great. So welcome back, everybody. And I mean, my goodness, the last few sessions speakers have just been fantastic. So thank you everybody much for that. And as you can see in the chat, thank you everyone for those lovely comments in the chat as well. Feeling the appreciation for everybody who's spoken this morning. So thank you very much. So I have the very great privilege and pleasure to introduce our next speaker. So I'd like to introduce Dr. Katie Featherstone, a Professor of Sociology and Medicine, Director of the Galloway Institute of Ageing and Memory, School of Biomedical Science, University of West London. So Katie's undertaken 5 years of research embedded in the acute wards across England and Wales, and the findings of this research have informed the delivery of evidence-based strategies to support the best practice in the care of people living with dementia. So we're very much looking forward to Katie to hearing more. So I'd like to introduce the brilliant Dr. Katie Featherstone. Thank you, Katie.
Thank you so much, Rebecca. I'm just going to start sharing my slides. This is always a slightly torturous part of the process. Let's see if we can get them up. Great. Does that work for everybody? I get them.
We can see them.
That's great.
Yes, yeah. Fantastic. Now, if I can just get them as
smashing, really good.
Yep, fantastic, great. It's fantastic to be here, and a lovely introduction from Rebecca. It's also just amazing to see the commitment and leadership in Wales. I think this is such a great showcase that we've seen already, the commitment to Wales, and also to say that Wales is really leading the way in this. The work that Lynn Sue Phelps has done, the Improvement Gymru are really leading the way, and all the nurses and people on this call are absolutely, you're all ahead of the game. We've got lots to do, but you are leading the way. And yes, I am in University of West London now, but my heart is in Wales, and all of this work and research would not be possible without the support of Welsh hospital boards. So really, really important that we are leading the way in this. And I want to continue that work with you all. So I think I just want to give you really an overview of what we know. We don't know everything yet about hospital care, but I want to kind of just really flag up what we know already and what we can do to use the evidence base to inform care, and what are the gaps. So I think Lynn actually underplayed the scale of people live with dementia within our wards. There's been a rapid transformation over the last decade of the number of people who are living with dementia within our hospital wards. And whenever I talk to a nurse in charge of a ward, they would say it's about a third of their admissions, but often it's half of the admissions within the wards. So we've seen this rapid increase, and actually people of kind of younger people and people of working age, 30s, 40s, 50s, are pretty much absent from our hospital wards. It's predominantly now older people. People living with dementia in our wards are typically at the early and mid stage of their dementia, and often for an unplanned admission. So people living with dementia are about over 70% of the unplanned admissions within our hospitals. And importantly, for a typically treatable condition. So this population are not there because of their dementia, but because they have a treatable condition such as pneumonia, sepsis, a UTI, a fracture. So they do require specialist acute care, and they should be going home. Another group is the person with dementia who arrives at A&E and actually could go home, but staff take a risk-averse approach and admit people for further observation and treatment in the hospital. So we have this significant population who should be going home and treated. However, they are incredibly high risk of poor experiences and outcomes. And as we heard from our speakers, such as Nigel earlier, absolutely the hospital is a very frightening place and can really cause significant iatrogenic impacts. And we really don't know the interaction between the hospital and the person's dementia fully, but we do know it can really have significant impacts on the person and the person's dementia. They're at high risk of distress, high risk of delirium, and that delirium being untreated. So this group have a really high short-term mortality, with almost a quarter dying during the admission. And if we have two patients who are admitted for the same acute condition, the person with dementia is at twice the rate of dying during their admission than that other person without dementia. So they've got that really significant risk of mortality during admission. And that's really what we need to change. But we've known about these poor outcomes for a long time, but we really haven't seen any transformations in these poor outcomes. So we've seen a number of responses from the NHS, and I'm talking here about the NHS in terms of England and Wales. This is not just Welsh research here. So what we've seen is significant responses. So they've intervened with new types of wards, such as care of the elderly, rapid assessment, cognitive impairment wards, frailty wards, which have all been aimed at delivering specialist care. But what these can also do is that they also start to really be seen as places that have very low status wards, that are seen as somewhere where actually people don't want to work. They can have quite a stigmatizing effect on the population, but also on the staff caring for them. And we see that in a large body of research which tells us this. We also see environments being changed. However, this is typically an environment and signage that often reflects the 1950s, which for our younger onset people living with dementia is actually can be quite an alienating environment as well. And we know that from a body of research too. We've also seen a lot of outsourcing of skills. So, today we've heard a lot about the importance of training and skilling up our workforce. What we find is, rather than that, traditionally we've seen over the last decade a focus on enhanced agency care, one-to-one care, specialist dementia support teams, which are fantastic, but really are not big enough to cover an entire acute hospital. We've also seen a lot of awareness and identification schemes. And I know we talked earlier about the dementia daisies. These are fantastic schemes, but if we do not have a workforce that is sufficiently skilled, these identification schemes and signage can also be potentially stigmatizing. So we have to use those with caution and only in a wider context of care and expertise. And what we find with all these interventions that have been tried so far is that wards are highly resistant to change. They are highly driven with timetables and routines, and actually intervening within those is, if you do it from a top down, is very difficult to do. What we need to do is start identifying and developing interventions, co-producing with staff, with people living with dementia, to reflect the routine organisation and delivery care, how work is done rather than how it's imagined by institutions and by the NHS, and also in ways that responds to the needs of people living with dementia. And the question of culture is really critical here. And this has been something that's been flagged up by many reports over the last decade as something that we really need to focus on. How can we improve cultures to really support people living with dementia, but also that really supports ward staff and allow them to deliver the high quality care that they want to deliver, that they're frustrated that they can't deliver. And that's what we find in the acute wards in our research so far. So how can we do that? Well, in response, there's a body research that we've been carrying out based in Wales, but carried out over Wales and England, looking at some key aspects of ward cultures, looking at everyday acute care. Our first study looked at resistance and refusal of care, how that distress in the person can manifest and what might be causing that in the acute wards. Why do people with dementia resist and become highly distressed? Looking at those social processes. From that, we went on to look at continence care as the really important feature, but also hidden feature of everyday care within acute wards. It's so invisible, but it's such a core part of care work, but also dignity for people living with dementia. Our current study, which we've just started, is going to look at restricted practices. Again, it's something that we identified in both studies, earlier studies, but something that again is very ordinary and everyday in some aspects of ward cultures. And we really need to understand what's going on so we can support people living with dementia, but also support staff. And that's ongoing, and that will be carried out in hospitals in Wales and England. All our research is co-produced. It involves co-applicants who are living with dementia. It involves nursing staff. It involves hospital trusts in Wales. People are involved in the research governance as well, and we have a big programme of outreach as well into the community to involve people in the research process. So far, I've been in hospital wards for over a year, really shadowing nurses, healthcare assistants, talking to them about the work and the challenges they face. And although I'm not going to focus specifically on our research today, it fits into a wider context of what we know about the acute setting and really it shows the organisation and delivery of care. The way care is organised really influences frontline care, really influences how staff feel they are able to deliver care and the constraints that they feel in able to deliver high quality care. So overall, if we look at the wider body of literature within the acute setting, looking at the acute setting, what it tells us is that despite staff aspirations to deliver a high standard of psychosocial care, the kind of care that Dawn was talking about, and the kind of care that I know you all are committed to, this is highly dependent on the social and organisational context at ward level. At ward level, we see the timetables, pace and time constraints really restricting what staff feel they're able to do. You know, that feeling of falling behind, that anxiety at every point in a ward where the team feel they're falling behind and are rushing to try and catch up with the timetables, trying to do things before the lunch arrives, before the round starts, before, you know, that sense of anxiety that can really be part of everyday ward life. Caring for older patients and people living with dementia can also often be viewed as heavy and de-skilling work. That can be within wards, but also absolutely a message at the organisational level that can really silo these wards as somewhere that senior staff don't go to, don't show their support to. At an organisational level, when staff are seen as spending time developing nurse-patient relationships, this can often be viewed as having low organisational value, and that can be in often because it is really not something that can be captured in the way that the key outcomes for patients can be in wards. Also, wards designated, as I said earlier, for older people and people living with dementia can often be viewed as having less institutional support and less resources. So they can really feel that feeling of being siloed, or feeling of actually they're also stigmatised as a ward as well. And this staff inability to fulfil their aspirations of delivering high quality patient care can really leave staff feeling incredibly frustrated and guilty, but it can also have wider impacts and really result in staff feeling emotional disengagement from patients. And this is a really, really tragic result of these organisational constraints. So this is from a really large body of literature. But then what does good care look like? Well, good care, as we've heard, this really echoes what we've heard all this morning, is around visible senior manager support, visible leadership on the ward. And I've seen some amazing teams and some amazing nurses in charge of the ward really deliver that leadership. But what I've never seen is senior managers visible in wards, showing their commitment. And I think this charter can really start to enable that to happen. We need that visibility of dementia care as a priority, person-centred care as a priority. And what does good care look like at ward level? In terms of bedside care, it looks like a slower pace. You know, when you, again, that feeling of falling behind, actually rather than speed up, it's about slowing down, seeing the person, recognising individual timetables rather than the oppression of the timetable of the ward. Time to listen. And as we've heard, care at the bedside is person-centred, seeing the person, but in very practical ways about supporting independence. That urge to encourage somebody to stay at the bedside, actually, but to support them to walk to the bathroom. Even that feels like it's going to take too long. That move and supporting someone to the bathroom is so important. That is person-centred care. And also recognising wider arrays to communicate and to see the communication of the person. Understand that embodied communication, that sense of anxiety in the body, in the person, the tapping of the toes, the anxiety, the trying to get up. What are people trying to convey? Do they want to go to the bathroom? Are they distressed? Seeing those, making time for those. And I think that's what I always see in wards, is that staff frustration and wanting the opportunity and space to deliver that level of person-centred care. But what you often find is that when I see that amazing care, quite often that is something that when we do get a senior person, for example, a doctor coming into the room, that can be really discouraged. It can be very discouraged. It can be, I've seen responses such as, why are these people out of bed? Get people back into their beds. Why is the ward disorganised? It needs to be tidy. So we also really have to, again, go back to the visible leadership within the wards and within the hospitals to really say, this is our priority, because it can quickly be stamped out. So I think that's where I think the Charter can really, really make a change. If you want to read my my work about the hospital wards, our work is totally open access, and you can download the work in from Amazon or from the publisher. It's totally free to download, and it's going to be an audio book soon to really support open access. So how are we using this research? Well, I'm really pleased to say that we've been been asked to be involved in the hospital charter, also the cross-party report on hospital care, and being part of those steering groups. It's been really, really important for us to be able to share our research in those networks. In terms of capacity building, we're very focused on supporting training. Within my new institute, we have a Master's in Dementia Studies, which is really aimed at supporting leadership, because that's we think is where we really need to put our resources. And also, Wales is leading the way, and it's about sharing our research with international networks. It's also about supporting those cultural shifts. I think this is where the Charter really comes into play. So we're doing a couple of things at the moment that I really hope you would want to get involved with. So please contact me, contact Michaela and Rebecca as well if you'd like to get involved. So we're developing some open access training, which will be mobile first platform. The first one's going to be looking at continence care. Really collaborating with nurses, continence specialists, dementia specialists. We've got to move wards away from pad cultures where we place everybody in a continence pad as standard. and I'm talking here about England and Wales. It's a really common phenomena, and we've got to move to a point of independence. This is supported by NIHR, by my institute, by Anara and Bevan, who we're working closely with, Cardiff University, and of course Improvement Gymru. And we hope to have a draft available soon to share and get comments back on. We're also focusing on how we can use this research to inform culture, the organisation and delivery of care, working with wards to help them to see their wards differently, to see the organisation differently, and think about how care is organised now, how care is delivered at the bedside, to think about how they might make some small changes to support the most vulnerable patients. You know, we know there is a lot of anxiety around change. We just have to go back to the Isabel Menzies list of 1960s, 1970s, where she really talked about trying to support wards in delivering change and organising care differently. And she found high levels of anxiety. So we have to take that into account. We can't just go top down. We have to support and listen to ward staff, to teams. How would they like to deliver? What are the challenges they face, and support them? And I'm pleased to say that we're working with Anara and Bevan as our first partners to support awards and to work with the ward team and work with people living dementia to really see how we can support that ward to improve care, with the thought that actually then we can start to support other wards across Wales. Thank you.
Thank you, Katie. Brilliant as ever, as usual, and thank you so much for talking about those important issues. Lots of thinking on the call for people, and lots of learning, but also thank you for talking about the good care that's happening as well, and those small steps that people can take to make a difference, and we're moving together. And thank you everybody for the conversation in the chat. Some really great points made there, but overall, talking about these things helps us move forward. So thank you, Katie. Thank you.
Thanks so much. I'm so passionate about this, and I think just because I've been in wards for so long and seen everyday care and seen the challenges, and I think this is a great moment to actually come together and see how we can take this forward. Thank you.
Thank you, Katie. Okay, so moving on to our next speaker, I've got the great pleasure of introducing Sue Feltz, MBE, the country director of the Alzheimer's Society Gymru, who's going to give us an overview of the cross-party report. Thank you, Sue.
Thank you, Rebecca, and hello everyone. I almost feel we could finish there, because Katie's enthusiasm and passion, and the fact that we are leading the way in Wales is great. Is a great note to finish on, really. But I won't finish there. I am mindful, however, that you all need to go and get some lunch. So I will be as quick as I can. And it's lovely to be able to wear some sparkle. I met the brief of the Premier, and actually I do feel really sparkly. What I've heard this morning is a genuine commitment to making a difference, and how teamwork is going to deliver that difference. It's a huge privilege, as Katie has already alluded to, working alongside Welsh Government, Improvement Gymru, local health boards, the brilliance of experts like Katie and like Dawn, but most importantly, working alongside those people with lived experience. They're the experts, we know that. And hearing from Kerry and Andy and Nigel, it just inspires you to get on and be better, to improve. So I'm going to talk a little bit about the cross-party group inquiry into dementia, which resulted in the report, which I've got here beside me, No Understanding, No Knowledge, No Support, and it will be available on our website at some point, so we will let you know when it's available for download. With an estimated 50,000 people living with dementia in Wales, I can appreciate to a certain extent that most of the people in this room who have been here this morning, I'm preaching a little bit to the converted, because you can sense that genuine commitment. But Dementia is an issue. It's not going away. As Nigel said this morning, there is no cure, and there will be an increased number of people living with dementia as we experience an ageing demographic. So many of you this morning, I would guess, are either touched directly or indirectly by dementia, and many of us will have that very personal experience. And anyone who has experienced dementia firsthand will understand how vulnerable people affected by dementia and those living with a diagnosis are when they're placed in an unfamiliar environment, such as a hospital ward. I would suggest that those of us who are not living with dementia at the moment would find hospitals frightening, scary, intimidating, confusing places. And the standards of hospital care can be difficult and emotive, and an emotive issue to discuss. And that issue has been exacerbated only by the experiences throughout the pandemic, the pressures that we've heard about placed on our NHS colleagues, our hospital workforce, and those in social care who complement those working in our health service. Reports such as the Older People's Commissioner's Dignified Care Report way back in 2011, but the findings still stand. Reviews into incidents such as on poor practice, such as Towel Van in North Wales and Trusted to Care in South Wales, they really shone a light on the most darkest of areas and worst practice that we've seen in Wales. And there has been an improvement since then, but there's so much more to be done. There's also been a lot of media coverage. We see it quite regularly on what people are not receiving. And that care is falling well short of what people have the right to expect. For too long, there's been an acceptance of almost a culture of valiant failure, the lack of compassion, dignity and respect. And that's resulted in a low expectation from people when they go into hospital. And that can't continue. So with the Welsh Government's Dementia Action Plan and the Dementia Standards Pathway, and now the Hospital Charter, we have a real opportunity to make a difference. The Dementia Action Plan was actually launched and was co-produced by people affected by dementia, involved the voices of over 1,000 people affected by dementia, as has the Charter. And it was really important that the statements, the dementia statements that are threaded throughout the National Dementia Action Plan were brought to life when the cross-party group on dementia looked at the possibility of an inquiry into hospital care. One of those statements, and I'll read it for you so I don't get it wrong, because it is a statement from people affected by dementia, it's their words, and they say, "We have the right to an early and accurate diagnosis and to receive evidence-based, appropriate, compassionate and properly funded care and treatment from trained people who understand how dementia affects us. This must meet our needs wherever we live." So that's one of those 5 dementia statements, and they reflect the rights of people living with dementia throughout all aspects of their life, and are particularly pertinent when put through the lens of hospital care. So why did the cross-party group on dementia focus on hospital care? And the chair, the then chair, Lynn Neagle, who we heard speaking earlier this morning, why did she commission Alzheimer's Society to conduct that inquiry? Well, we heard from Lynn that she has personal experience, and she had personal experience through caring for a loved one in her family who'd received poor care in hospitals. So for all the reasons that we've heard about this morning, and have been so powerfully articulated, and the quote that's on the holding slide there, "It must have been absolutely traumatic for my dad. No understanding, no knowledge, no support. He couldn't communicate." That came from a carer. That is the reason that we decided to embark on the inquiry. People affected by dementia have been consistent in their pleas for improvements in the standards of care, where in a place where they are most vulnerable. But we also shouldn't forget our doctors, our nurses and support staff, the majority of whom are trying their utmost to deliver excellent care, but in the face of increasing challenges and pressures. And we've heard some of that in the chat this morning. Hospital care for people with dementia has often been overlooked, and I guess because it is, on the face of it, complex and challenging. So a little bit of how we've heard quite a few statistics, not least that a quarter of our hospital beds in Wales are occupied by people living with dementia. We have, I'm just reading here, 42% of unplanned admissions relate to people living with dementia, and the readmission rate for people living with dementia is far higher than for those people without. So there are lots of reasons why we needed to conduct the inquiry. The how. So we wanted to conduct an inquiry that was robust, that could stand up to scrutiny, and took quite a time to plan the how. So we had a number of surveys, and those surveys reached both qualitative and quantitative. They were online. They were delivered via face-to-face interviews and delivered via focus group discussions. And we had over 2,000, well, nearly 2,500 actually responses across all the survey platforms. And actually one of those I would like to highlight is one that we hadn't considered, but very quickly plopped into the survey, was the care home survey, because it became very, very apparent that the transition from people living in care homes in and out of hospital was quite a critical point for failure. And we wanted to hear from care staff and their experiences of their expertise, sometimes being ignored when they were supporting somebody to move from their residence in a care home in and back out of hospital. And that sort of tension between the expertise perceived in the health service versus that in social care, and the real need to rebalance that and respect one another's expertise in light of what they could offer the person at the heart of the care. So we also held roundtables across constituencies, and a number of our members of the Senedd, or Assembly members as they were then, supported us with that. So we held roundtable discussions in Pontypool, in Wrexham, in Newport and Llangefni, and we had nearly 40 people engaged on those roundtables. But we also, and that's people affected by dementia, but we also held roundtables with partner organisations like Macmillan, the Royal College of Nursing, and student nurses, really important cohort, those people learning what it's all about to deliver excellent care. So that was valuable insight from those groups. And we had written responses as well from members of the public, from local health boards, from the Royal College of Psychiatrists, Royal College of Speech and Language Therapists, the National Federation of Women's Institute, the All Wales Mental Health Forum, and the Older People's Commissioner. They're just a few of some of the written responses we got through. And we held an oral evidence session. One of the CPG cross-party group dementia meetings was given over to oral evidence with Age Gymru, the Royal College of Nursing, and Katie, Professor Katie Featherstone was there as well, delivering her work. In addition, we decided we wanted to get out there and be visible in our hospitals and really hear what it was like on the front lines. So we pulled together a roadshow across Wales, and we visited 10 hospitals in Bronglais, Aberystwyth, Prince Charles, Merthyr, Royal Gwent, in Newport, Brecon Memorial Hospital, our University Hospital in the Heath, Cardiff, Ysbytai Gwynedd, Bangor, Wrexham Mylor, Singleton Hospital in Swansea, and Victoria Memorial Hospital in Welshpool. And they were brilliant in as much as that they were members of the public who were coming in to visit patients on the wards. They shared their experiences. We had staff coming to us, and they were nurses, consultant psychiatrists, geriatricians, but support staff like the porters and the receptionist admin staff, all sharing their insight as to what they experienced, and shared their knowledge and understanding of dementia and what they felt could be done to improve that knowledge and experience. So I'm going to share a few some of the findings from those surveys, roundtables, etc. 56% of respondents across the surveys rated dementia knowledge of medical staff as average or worse. So that's over half of those respondents. felt that knowledge could be significantly improved. 54% of respondents rated the experience of accident and emergency for people living with dementia as average or worse. And a quote here from a person, a carer of a person with dementia: "All staff that my mother came into contact within the general hospital, and especially A&E, have no idea how to approach a patient with dementia." The top areas for improvement were dementia knowledge of medical staff and coordination of services. Despite admissions and discharge having 75% and 72% average or worse ratings, actually they came quite low in terms of people viewing them as important priority areas for improvement, which was surprising. 35% of respondents rated communications between wards as top area of improvement. We've heard a little bit about that this morning, communication. Another quote from a carer: "Getting mum onto a ward that was in any way suited to care for her was a nightmare, a real nightmare. We had to row, argue, shout, and be threatened by nursing staff who would not allow us to stay with her as carers. They were unwilling or unable to give the level of care that is needed." That's really quite shocking and quite stark. So I'll leave that one. I'm going to move on to the solutions because I'm mindful of time and I don't want to take any more of your time. Some of the solutions, we absolutely wanted the inquiry and the resulting report not just to be about bashing our colleagues in health and social care. It was about finding practical ways that we could work together as a team, cross-sector team, working with people affected by dementia to make some real difference. So some of the solutions in A&E, the creation of quiet spaces away from main seating and waiting areas where people living with dementia could wait on arrival to A&E. Care within the hospital, wards to move away from condition-related and task-based towards person-centred, holistic approaches, which we've heard so much about this morning, and Katie's work, Wandering the Wards, will help us, and Dawn's work will help us do that. Discharge, hospitals to trial set discharge slots for people living with dementia to enable care homes, carers and family members to support, understand and contribute to the discharge process. So having dedicated slots, and people told us slots between 9 AM and 11 AM and 4 PM and 6 PM would really help them focus that discharge time and plan more effectively. Care across the hospital setting, so the development of an approach to learning, development and training based on individual staff need rather than a blanket approach. When we spoke to our nursing colleagues, what they said was that they do get a lot of training, which is fantastic to hear. The issue for them is they can't put that training into practice. And that is something that really needs to be addressed. There is a will, there is the training there, but the capacity and the leadership to enable that is so important. And then care homes, a strong voice from care homes, hospital to work more closely with care home colleagues to draft joint working policies to allow care home staff where appropriate, for example, to come in with a resident to assist with somebody's care, to ensure that the "this is me" is enacted and responded to. And a simple thing like insurance, we had no idea that there was no insurance cover that could cover a social care practitioner in and out of hospital with the residents. Surely it is not beyond the wit of man to come up with a joint insurance policy that would cover a member of social care staff to support that person in and out of hospital. And then, of course, last but not least, the hospital, dementia-friendly hospital charter. This is going to be such a tool to drive forward change and to monitor impact against, which is going to be so important. And it's been a privilege to be involved with the development and the evolution and hopefully the implementation of the charter. So to close, although the inquiry, it did deliver a comprehensive and robust scrutiny of dementia care in hospitals, the final report, we have to be honest, does just scratch the surface with regards to significant issues on, for example, how do we fill over 1,500 nursing workplaces, you know, the massive issues within the workforce, and also rebalance the integration between health and social care. That's bigger than the report, but it's definitely still on the table. Instead, I hope what's presented in the report are attainable, achievable solutions to making the hospital experience one that is positive for people, that the Deputy Minister alluded to this morning. An opportunity to, quote, build back better. The acceptance of a culture of valiant failure cannot continue. The number of people affected by dementia is set to rise by 2050 to over 100,000 people. That is a huge, huge number of people. And therefore, the pressures will continue. They're not going to go away. The challenges and pressures will not go away. But by uniting across the sectors, by focusing on the key actions laid out in the Dementia Action Plan, in the Dementia Standards Pathway, implementing the hospital charter, but most importantly, continuing to put the voice and lived experience of people affected by dementia at the heart, we will shift the culture that's needed, and we can drive improvement. As Nigel said earlier, and I wrote it down, Nigel, listening, hearing, and doing something about it leads to positive change. We can do it. Thanks ever so much. Enjoy your lunch and see you this afternoon.
Thank you, Sue. Thank you very much. And thank you for sharing the important work of the Alzheimer's Society and the cross-party group. Really important messages there for people. So there's been lots of learning this morning, lots of things that we can do. But we've also heard about the really good practice that's going on as well, and really building on that. So the hospital charter is very much going to be a vehicle to support us moving forward that, and that's to us as partners, and I say partners, I mean everybody on this call as partners, to take things forward. I'd like to just to let you know now it'll be lunch, and so we're going to break.
Right, hello everyone, welcome back. Apologies for the short lunch. Could you all give me a clap just to make sure we've got some people back with us? Does everyone know where that is? In the reactions, lovely. We're seeing lots of clapping. Fantastic, that's what I like to see. So, welcome back everyone to the second half of what hopefully will be a really great afternoon. In fact, I'm sure it will be. Hopefully you've had a chance to get something to eat and stretch your legs, but we're going to get right back into it with an executive panel today. Firstly, I would like to thank everyone for giving up their time to be on the panel today, and the details of the speakers and their roles are added onto that little slide at the bottom. But firstly, I would like to introduce the host of this panel, Betty George. Betty is a fierce advocate for improvements in dementia care after having personal experience of caring for individuals living with dementia. Betty, thank you very much for joining us.
Deall, Ian, a prynhawn da I chi gyd. I like that description, fierce advocate, but somebody who's banging her head against a brick wall may be a better one, because that's how it feels very often. Yes, I've had direct experience of dementia care in hospital. 5 years ago this week, my David died. He'd lived and yes, suffered with Alzheimer's for about 8 years. And a month before he died, he'd spent a week in hospital with a chest infection. And to put it mildly, it wasn't a pleasant experience. In fact, though the chest infection had cleared up in 2 or 3 days, he came out of hospital in a worse state than when he went in. I won't go into details, there's no time for one thing, but also we're discussing the future here today. And I'd like to thank the 7 executives on the panel representing the health boards for being brave enough to deal with a few questions, because implementing this charter is a challenge. We can't get away from that. And we've heard how leadership is vital if it is to make a difference. And I'll have to remember that we've only got half an hour for this discussion, so we must be aware of timings. I hope to squeeze in 5 questions. So the first one, since a quarter of beds in hospitals are occupied by people with dementia, dementia care, I would have thought, must be regarded as a priority. And there must be a vision. So in 5 years' time, what might dementia care in hospitals look like? It's a question for Dr. Richard Evans and Jill Harris. And Richard first, please.
Thank you, diolch Betty. Prynawn da, good afternoon everybody. Yeah, Betty, I was reflecting when you were talking then about your David that I think given the challenge of cognitive impairment and dementia in the population, there can't be many of us now that haven't had a direct experience of that, aside from people who are clinicians and seeing people in hospital. Actually, it's so prevalent, isn't it, that we're seeing friends, family, whether it's friends, family, who are suffering, and the challenges not only that the individuals face with that, but obviously also the people that are caring for them. I think, Betty, in terms of your question about hospitals, I think there are two aspects to that. And the first is the recognition that not everybody who has cognitive impairment needs to be in hospital, and often currently, because we're not able to provide the right care in the right place at the right time at home, hospital ends up being the place of safety. And so I think the first thing for us, and I think the Dementia Charter is very helpful in setting up that challenge for us, is to acknowledge that hospital often isn't the right place, and what we need to do is to strengthen the services that we're providing in the community, but also strengthen the support that we give to families and carers of people with dementia and cognitive impairment, because it's often they who are providing the first line care and often feel under supported by the system. So what else can we do? Needn't take things over, but it's what do we help to keep people in their own homes. We know only too well that once you bring somebody with dementia into hospital, it's terribly confusing. People often become disorientated and out of their usual routine. And your experience, Betty, then is that people get worse when they're in hospital because they're in an unfamiliar environment. So there are lots and lots of benefits for making sure that our services are geared towards managing people in their own homes. There are, though, but unfortunately, dementia, cognitive impairment are things that come with older age, and other things happen, other diseases, other conditions, that does mean that people do need to come into hospital. So the second point I'd make is that when people do need to come in, we need to be making sure that we're providing an environment that makes them feel as comfortable and as secure as possible. So the environments are friendly, but also that we've got the staff, that our staff working with us are trained in the care and the healthcare needs of people with cognitive impairment and dementia, so that we've got a true understanding of what that means. And there are several things aside from the charter, and there's John's charter as well, where we're working with our staff and our partners to put that to make that happen going forward. And then finally, in terms of that hospital care, there's a very critical group that we all rely on in that, and that's our volunteers. And they play a really important part as well in the way that we provide care in hospital. And that's obviously often not direct clinical care, but it is the sort of care around the individual that helps them feel supported in that environment. I'll stop there, but I've got plenty more to say.
Yes, exactly. That's a sad thing today, that we could go on for hours, but unfortunately time is against us. So I'll move on to Jill. Jill, please.
Good afternoon, and thank you for inviting me to be part of this panel. Completely agree with what Richard said about there are a few of us who are untouched by dementia in our own lives as well as within our working lives. I see that you're fierce, but I think that's what's necessary right now. We have a challenge, it's a necessary challenge, and it's good to pick up that gauntlet and say what our vision needs to be. And Richard, you've unsurprisingly stolen a lot of my thunder, because you talked about the 25% of people that are in our beds, and many of those should not be there. There has to be alternatives, better alternatives, and better support for those people that are caring for loved ones in the community. So that has to be part of our vision. I think, again, Richard has touched upon it, but we need to be, our vision is that our environments are the right environments when people do have to come in and require acute care. And I think the trauma that many of these people feel about going from a familiar environment to an unfamiliar environment needs to be recognised, and we need to support that. Added to that, I think we know patients are moved in our hospitals, and that is inappropriate. It's very inappropriate for people already confused when they enter our premises. We talked about people being prepared and ready and welcoming. So Richard mentioned the fact that we need the staff that are absolutely able and trained and facilitated to both recognise the care that these people need, our loved ones, but also be able to deliver it and be able to support unpaid carers and delivery of that care. We've got loved ones who need to be welcomed to support that care and to make that environment as familiar as it can be, albeit that necessarily it is unfamiliar. So we need to ensure that every time they are welcomed alongside that individual to help to support their care. I think the vision is that we're endorsing the Dementia Hospital Charter, but we want to look at all our standards, including how we respond to our complaints and really learn from them, and bring alongside those people who are really experts in care. And those are the people that are living with these people day to day. Our plans will be holistic. They can't be piecemeal. And we need to capture the opportunities to drive up improvement and embed the learning from each of the opportunities that come into the fabric of the health world. And that includes really listening. And I mean listening, because sometimes we're in a conversation, but we don't hear what is said. So I think there's a lot of learning to be done, but in transforming our services in hospitals, we have to transform the services and support that we give in our communities.
Thank you, Jill and Richard, and we'll go on to the next question. As I said, implementing this charter is not going to be easy. It will require huge commitment. It's a huge undertaking, isn't it? So how are you going to make sure that the charter's principles remain a priority for hospitals? And this question is for Liz Carroll and Lauren Edwards. Liz first, please.
Thank you, Betty, and I think that's a really important question, you know, in terms of the priority. We're the largest geographical health board, and we've got a number of general hospitals, we've got a number of community hospitals and older adult mental health wards, so getting that priority shared across such a wide geographical space and quite diverse kind of hospital environments is a challenge. So to that end, a steering group within the health board, which is for the dementia friendly hospital charter, and that group has met, and it includes people from all of that range of areas that I've just described, and you know, it's the lead for that steering group is one of our district general hospital head of nurses, so we've taken, you know, real pride in having that leadership sitting within the general hospital senior nurse roles. And just referring back to Katie's presentation, so those senior visible leaders are really critical in driving this through, and that the head of nursing also sits on the national group as well. So all of our hospitals are signed up to the dementia friendly hospital, and we've got the subgroup. And each of the main general hospitals have got a project area that they're going to be leading on. So one is going to be looking at dementia-friendly hospital design, one is looking at governance and dementia training for staff, and then another one is looking at dementia care mapping, and this is me. So that, you know, everybody's got a part to play, because we can't concentrate this in one place, otherwise we don't get that sort of wider sort of cultural change and awareness, really, so that it becomes something that's about everybody's input into this. So it's really critical and really. The steering group is meeting, so obviously we're going to be undertaking the VIP self-assessment. That's not been commenced as yet, but preparation is underway, and will be done across all of our district general hospitals and older adult mental health wards as well, because we don't want to leave them out of this, even though there's been a lot of work done in those clinical areas previously around dementia-friendly environments. There's always improvements that we can make and learn, so people are aware of the Improvement Cymru Padlet and the supporting resources that are available. I guess from a regional partnership or dementia steering group perspective, our commitment is that we've got a dementia programme and I can't think of the title now, change management lead, and that role reports to both the regional programme manager and the senior responsible officer for the delivery of the National Dementia Action Plan. So, you know, we're making it a priority for many, not just for one. I think that's key in delivering this. Thank you.
Deall, Liz. Lauren?
Deall, thank you. Just to echo a lot of what Liz has said, really. So you're right, it's a large undertaking, but we think it's an exciting time for dementia care, and that's how we're viewing it across Cwmtaf Morgannwg. And we feel that we put an infrastructure in place to help us maintain that focus and priority for us as an organisation. So we've got the established dementia board with the 6 work streams, and one of those work streams is specifically dedicated to the hospital charter. And that work stream is fully engaged with a range of stakeholders and has a developing, a constantly evolving work programme to design and deliver the intentions and the priorities that are outlined in the hospital charter. We've identified dementia leads for all of our hospitals and are making sure that their focus is progressing the learning and development of our workforce, referencing the Good Works framework. And we're committed to using the new VIPs tool as well. And that is a tool that allows us to continually monitor our progress through the ward assurance programme. So we think our new structures and identified leads will help us to keep this really important topic at the top of our agenda. The work of the Dementia Board is really central to our developing organisational strategy, so CTM 2030, and it's highly visible to the board. So we've recently had a board development session actually that was delivered by the chair of the regional partnership board. So we're making sure that at every level it's everybody's business, like you were saying. So we feel that the partnerships and the collaborations with a whole range of stakeholders that have been developed are key to maintaining the energy and commitment to prioritising the principles of the Charter. And I think, you know, it was Nigel's comments at the opening of the day that co-production has got to be the cornerstone. So that's how we think we're going to get, you know, progress on this journey as an organisation.
Thank you, Lauren and Liz. And we'll move on to the third question. It's about the knowledge, skills and understanding required when caring for someone with dementia. And of course, that means training. And every adult ward in your hospital is likely to have a patient or even patients with dementia or some form of cognitive impairment. So how are you going to make sure that what is required when caring for a person with dementia remains a priority for the workforce, and who will be responsible for ensuring that this happens? And we've heard already that there is resistance to change, isn't there? So this question is for Suzanne Rankin. Suzanne, you there?
You're very faint, Suzanne. We can only just hear you.
Shall we ask Carol Schiller?
Yeah, very happy. Diolch, Betty, Prana'n da pawb. Hello, everyone. Just while Suzanne sorts out the sort of microphone issues, thanks very much for the invitation. So I know time's short, so just a couple of headlines for us. We know that the quality of care and service relies wholly on staff or workforce right the way across the system, and how well prepared and equipped they are to do the very best job that they always intend to do. So here in Powys, just a little flavour of what we've been focusing on under our health and care strategy called A Healthy Caring Powys. We've got the development of our Health and Care Academy, and I'm delighted I saw a colleague from PAVO, a voluntary sector organisation who's in partnership with us here in Powys. Under that academy, we've got a school of professional training and development, of course, for what we'd call our sort of paid workforce. and then a school of volunteers and carers for the army of people who we work with in partnership to develop the very best care possible. So that is really a focal point, and our dementia network plugged into those developments to support people who have that caring role, paid and unpaid role, in order that we prioritise this key development. And congratulations, I would just say, on the development of the Charter. I think it's a fantastic opportunity for us to grab hold of here in Wales. And in terms of who's responsible, the board itself has a responsibility here for overseeing the developments. But in terms of executive level, our Executive Director of Nursing and Midwifery and our Executive Director of Workforce and Organisational Development hold this for us in partnership with the Regional Partnership Board. Diolch, Betty. Thank you.
Diolch yn fawr, Carol. Is Suzanne available now? Has her mic been sorted?
Betty, can you hear me?
Yes, I can. So, would you like to come in?
Right, very good. Okay, very briefly then, just building on what Carol's described. I mean, I'd agree entirely, Carol. The board is accountable for delivering on the ambitions of the Dementia Hospital Charter. And within that, I think there's collaboration across the executive and with the Regional Partnership Board. And we've certainly gone about it in that way. So we've established our dementia plan. We have a dementia delivery group. But this is about culture, fundamentally, culture of practice. I think it's for me and the board to establish role model compassionate leadership, so that can be felt by the team and therefore by the patients. This is really everybody's business. So we've got a comprehensive approach to training. We've got a dedicated dementia training team. But I think it's important to stratify the team and ensure that we prioritise those, the team around the patient and their carer and loved ones first. But everybody in the health board will need to be trained to manage and interact with those with dementia and Alzheimer's appropriately and compassionately and with kindness. And, I go back to what Nigel said this morning. If you get it right for those, we will get it right for everybody. And we know there are challenges in achieving that at the moment. I think co-production of different kinds of innovative roles is really important. So we're working on developing educators that are those with lived experience, predominantly carers. And I think that'll be a really important innovation for us to continue to develop. Volunteers are really important in this field, and those from the third sector with deep experience and knowledge. And I think we've got to really demonstrate that we value carers. And on the back of the dreadful, separation that the pandemic has caused when patients are in the hospital, we've really got to rebuild that approach, I feel, and ensure that carers are welcomed and enabled to come into the hospital setting and support the delivery of care and lead us in an understanding about the needs of their loved ones. And finally, there is something really important about the environment, which others have already spoken of, but I think the environment both contributes to an improved experience for patients, but also for the team, and points them to the need to pay attention to these challenges. So I think that's something that we really need to capitalise on as well. So thank you for the opportunity to speak, Betty.
Suzanne and Carol, thank you very much. And we'll go on to question number 4. The emphasis in this charter is on person-centred care, which means moving away from traditional models of care in hospitals. This was highlighted in Professor Dawn Brooker's presentation this morning, and it saddened me to hear Katie Featherstone say that she witnessed a high resistance to change. So please, can you commit to supporting areas to try out different ways of working, new initiatives, and the need to be more creative? And Rhiannon Jones, would you please take this question?
Yes, thank you, Betty, and Pronang Dda. I think in answering this question, in reality, I could probably just answer it in 4 words, which is yes, we are very committed, but allow me to expand a bit. I heard the speaker just before lunch talking about staffing deficits, and I think it's important to touch on that. The World Health Organization have actually predicted a shortage of health and care workers in the region of 18 million worldwide by 2030. And the King's Fund have identified a shortage of some 250,000 care workers across the UK by the same time, 2030. And we currently have 1 in 11 care roles unfilled. So I'm sure that everybody would agree that these figures are stark, and it means we have to work differently, we have to work creatively. And in response now, I just want to take a slightly different slant, which I hope is not going to be too controversial, but we'll see. We've got to be creative and innovative, and we have to have future generation thinking to address the challenges of health and care, to include dementia and to improve the care experience, both in terms of positive patient and care experience in hospital, but it's wider than hospitals. Positive staff experience also, because through the pandemic, we see a lot written and lots of evidence about moral injury, but ensuring safe, high quality care based on evidence. I think there's many examples across Wales of different models and innovative approaches to improve the experience for people living with dementia in our hospitals. And from an Aneurin Bevan perspective, I've got 2 such examples. We've commissioned Rita Unit, which is the Reminiscent Interactive Therapy, which is a digital platform. And we've recently introduced Dementia Companions, who are volunteers, and both Suzanne and Richard mentioned the importance of volunteers. I've got a quick vignette that I just want to share, and this demonstrates the impact of the Dementia Companions, but also the use of Rita. And this is from one of our companions. I was playing chess with a patient. The patient had dementia, and we were chatting. He told me he used to love watching horse racing, and he used to like the odd flutter. I used the Rita Unit, and via an app, we engaged in horse racing and virtual betting. It was great fun, and it was lovely to see the patient so happy. These examples are really positive, but I believe there's much more to do, and there's opportunities to consider social robotics and artificial intelligence, which could be a game changer and an experience changer. Social robotics is relatively new in healthcare, but it could be a huge opportunity to work innovatively in the future to address the challenge we collectively face. We're all aware of Ask Alexa. Some of us will have robotic hoovers, and there's now the presence of self-driving cars. I'm sure many of you may remember the ITV programme Humans. This was a drama with lifelike humanoids called synths, and it was set in a parallel present. This may sound like science fiction, but we are using artificial intelligence today to assist with brain surgery. Social robots could be that game changer and could be part of the care solution as an extension to health and care with careful programming, design and ethics. So I believe we have creative approaches here and now, but Wales could go bigger, they could go better, they could go further for the future to ensure full compliance with the dementia standards and importantly the hospital charter to improve the experience of people living with dementia across our hospitals and wider. Diolch.
Diolch yn fawr, Rhiannon, and we could spend some time expanding on those issues that you've been talking about, but unfortunately we have to move on to the last question. Being in hospital with dementia can be a distressing time for not only the one with dementia, as well as I know and many others know, but for the family and carer too. What message would you wish to convey to them so that they feel they are supported during the stay in hospital? And I think I'll bring in Richard again.
Thanks, Betty. I think I mentioned in the opening remarks about you know, the need to create those environments in hospital, not only for the patient but for their carers. And I know one of the things that carers will often be concerned about is when they leave the ward and look back towards their loved one in the bed, wondering whether they're going to be okay. And I think that's what we need to bear in mind, don't we? It's the experience of the individual and the family, and whether we're providing that assurance to them that everything will be okay, and actually the standard of care that we're going to provide is up there with the very best. In terms of how we do that, I think, you know, interesting to reflect. I don't think many of our jobs are the same now as they were 2 years ago, and certainly the way that we're delivering clinical care is different. And while that's changed, I think what that has taught us is that we can change substantially for the better and deliver things in a very different way. And I think we just need to embrace that and to reflect on our experience of COVID, of what is possible, what is doable. It's not impossible. And to use us, well, certainly as executives and as senior leaders, our skills in terms of influencing staff to encourage those changes and mandating those changes is something that's necessary moving forward. I think, you know, just reflecting on what Rhiannon was saying there, you know, we have moved forward. Certainly in Neath Port Talbot Hospital in the last 12 months, we put in a memory impairment advice team, and we know from feedback from the ward there's actually been a reduction in the number of incidents of distressed behaviour amongst patients. So we know that we can put these things in and that'll have an effect. We've got an older person's assessment service at the front door of our A&E in Morriston, with the aim of seeing people at the point they arrive. So rather than let people come in and have to stay overnight, actually, let's see what we can do to turn people around right away and actually support them back in their own homes. And then I'm sure many of us will be the same. We're looking towards implementing things like therapeutic interventions like reminiscence, like music. Rhiannon gave horse racing and chess. But those sorts of things that actually, they're small, aren't they? They seem small superficially, but they're so meaningful to people and they have such a big impact on people's experience while they're with us.
Absolutely, Richard. Carol, can you expand?
Yeah, lovely. Thank you. Thank you very much. So I wanted to start with going back to the charter. So this is a chart. So the key question, I think, is about what messages do you want to send? So this is a really key charter for Wales. Importantly, it's a key charter for people with dementia, their family and their carers. But it's a charter for us as well, for people who work in the service, wherever we work. This is a charter for us because the intention is to really make a difference, and that's why we come to work every day. So this is a commitment, and this is a commitment that's been made jointly, and it's therefore a partnership. And out of the principles that stood out to me, partnership seemed really key. So all